Dr. Aisha Terry. Welcome to ACEP Now. You are the current ACEP president and joining us like we do with every year with every ACEP president. So welcome and thanks for being here.
Well, thank you so much for having me, Dr. Dark. I am experiencing a little bit of laryngitis right now, so excuse the voice, but it's a pleasure to be here.
Well, it's good to have you. And if you need to take a break for your voice, just let us know and we'll pause. And the beauty of not doing this live is we can stop and edit as we need to make it go as best as possible. There are a few big topics that I want to get into today. One is going to be about leadership and mentorship. One is going to be about ownership in emergency medicine. And then, of course, we're going to circle back around to the boarding crisis. But first, let's start with leadership and mentorship within the college, within emergency medicine. It's one of the things that you and your presidency hope to do, talk about mentorship within the leadership pipeline of the college. And what are your plans for this?
So I'm really glad that you brought this topic up. It's certainly near and dear to my heart in terms of not just leadership, but leadership pipeline. We know that leadership is really about supply and demand. There's never enough of a supply of leaders for the demand that we have. And we're seeing in emergency medicine now more than ever that indeed there is a demand for more leaders. We are facing unprecedented crises in various ways, and we need manpower. We need people on the ground taking care of patients, but also being leaders even outside of the clinical setting. And so my goal for this year, keeping in mind, everything that we're facing in terms of workforce challenges and the like, is to really focus on upstream efforts for pipeline enhancement. Leadership pipeline is really about seeking out, recruiting, preparing, and retaining leaders. Leaders in our specialty, future emergency physicians. And I think it's really important to start upstream, meaning we have to start with our medical students and residents, certainly, in terms of that development. One of the things that I hope to do this year is develop a leadership pipeline portfolio for the college. And the way that I plan to go about this is really, first and foremost, taking our story on the road. One of the things that I think we don't do enough of as emergency physicians is talk about ourselves and how amazing our specialty is in terms of what we do for patients every day. We need to take that story on the road to make sure that our future emergency physicians and medical students are aware of what an amazing specialty emergency medicine is, how we are really the quintessential specialty when it comes to health equity, when it comes to the safety net of healthcare in this country. We were touted as being heroes during the pandemic. Well, we're still heroes, and I think we need to ride that story out a little bit more. And so my plan is this year to visit multiple venues wherein there are future emergency physicians there to tell them the story of why our specialty is so great. ACEP, for example, will be partnering with AAMC this year, and I will actually be speaking at a couple of their career fairs. We plan to exhibit on their floor. AAMC actually has several pipeline leadership programs already underway that are really outstanding. And so my thought is that we need to partner with some of these organizations like AAMC to ensure that we have a continual pipeline of leaders.
All right. Well, you had mentioned also the workforce, and that's one thing I wanted to talk about. One thing that our readers and listeners actually want to talk about. ACEP had this workforce report that came out a couple years ago. The data was coming from the pre-pandemic phase, and I think there's been a lot of changes into the assumptions that go into making predictions like this. But it's something that we need to think about as a specialty because people matching into the specialty have heard about it. People deciding whether or not to support emergency medicine residency programs have looked at the ACEP workforce report. Do you think that it's something that ACEP needs to redo in the post-COVID phase when these assumptions may have changed?
So it's a great question, and the workforce study was actually an effort on the part of multiple organizations, including ACEP. We know that the variables have changed for sure. Workforce is about, again, supply and demand. And when that original study was done, it was based on variables that have changed. So, for example, the rate at which we're seeing increased numbers of residency programs is higher than what was included in the original study. We're seeing more residency programs come into the mix, which of course impacts the formula. We also know for sure that the attrition rate for emergency physicians has changed. That original study was based on there being about a 3% attrition rate. We actually have looked at the data again since then, about a year ago in 2022, and the attrition rate is now up to about 4 to 4.5%, and some estimate that the attrition rate could be as high as 7%. And so now in 2023, at the end of 2023, who knows what that attrition rate is, and if the trends follow, it's even higher than the 4.5% that it was a year ago. We know that we're seeing increasing numbers of nurse practitioners and physician assistants practicing in emergency departments alongside physicians. And so that also is another variable that goes into the mix in terms of workforce relative to supply and demand. So we actually have talked about, as a community of all emergency medicine organizations, about taking another look at that workforce data, plugging in the new variables, seeing how it's going to impact the really the prediction, because even a year ago, Dr. Dark, the prediction of the amount of surplus in terms of number of emergency physicians had actually decreased by about 65% compared to the original predicted surplus. So certainly it's worth looking at again. We're thinking that it likely will happen. It hasn't been, confirmed, but most of our epidemiologists and experts are saying that looking at that data again, truly post-COVID, would probably need to take place around the end of 2024 or sometime in 2025.
Okay, thank you. Well, just what do you think is the future of the emergency medicine workforce?
I honestly think that the future is bright. We certainly are facing some challenges, but some opportunities. We are seeing already changes and improvements in terms of interest in our specialty this year compared to last year. So, for example, the preliminary ERAS data is showing definitely increased number of applicants to emergency medicine this year compared to last year in 22, as well as 21. Again, I think that it's just about being very deliberate and intentional about our message. It's about being intentional about leadership pipeline and ensuring that we get out there amongst, the future, which are our students, our medical students, our residents, and really highlight the important and amazing features of our specialty. We are working really hard at ACEP to work on the environments within which we practice. We realize that, again, even just the environment of our workplace could be improved when it comes to workplace safety, when it comes to staffing, when it comes to boarding. These are all aspects of our practice that impacts interest in our specialty and that impacts how much we love going to work each day. And we are moving the needle on these really vital and important challenges that we're facing. And so I have no doubt that the future really is bright. We're not the only specialty to be going through this bit of a evolution, if you will, in terms of where we find ourselves relative to workforce. Anesthesia had a similar scenario actually over a decade ago, where their match numbers were impacted in the wrong direction. And essentially, they honed down, made some adjustments, and now are thriving. So I have no doubt that we will be just fine.
So in recent years, we've seen like several ACEP leaders, representative, a lot of minority groups. We've seen a lot of just even thinking like presidents, women, Asian, Black, etc. And it seems to me, just looking at it, as an observer, is that diversity and equity is being well represented within the college at the leadership level. What do you think the college is going to be doing moving forward to maintain this kind of focus on these efforts, especially considering sort of the national picture and the national milieu that's changed over the past year?
The college actually made diversity, equity, and inclusion a very specific initiative and priority several years back, with the development of a diversity task force. And from that task force's efforts, we developed a committee around diversity, equity, and inclusion, as well as a section within the college so that we have, the assurance that there's perpetuity in terms of this work that really can't just be accomplished in a year or two. It really has to be an ongoing commitment to really changing the fabric of the college and the culture of the college relative to a commitment around diversity, equity, and inclusion. I think that one of the key pieces to ensure that we continue to have a diversity of leadership, again, goes back to that pipeline. We have to realize that actually only 39% of emergency physicians are women. And so we would rather it be a little more reflective of the general population. If we could get up to at least 50%, that would be ideal. We also know that about 35% of emergency physicians are from minority backgrounds in terms of race and ethnicity. That's all of the kind of non-Caucasian groups. And so, again, there's definitely some room there for us to enhance the pipeline relative to diversity. When we do that, we will see that shift into ongoing diversity at the leadership level within the college. And so I think we have to, again, think about it in terms of there being a pipeline that has to be built out and focusing on those upstream efforts to really get the denominator right at a level where, having ongoing diversity at the leadership level is a breeze.
What can you tell the members about that leadership and diversity at that level? Who's on the ACEP board these days?
Oh, it's a good question. So my fellow board members are amazing, actually. It is really a group of 15 individuals who are incredibly passionate about our specialty, about our college, committed, and they work incredibly hard around the really robust agenda that ACEP has. I mean, we are essentially all things emergency medicine. And so you can imagine how great the work is, how robust it is. And I have the pleasure of working with a group of board of directors who are talented, diverse, from various backgrounds, from various types of professional settings, ranging from academics to private practice, to locums, to military, and the like. And so, we have talent ranging from IT background to health policy, to rural practice. And it's just really a delight to be surrounded by such a diverse group of talent who's very passionate about the work. They're truly my friends, and my colleagues. And so, I think that I personally would love for the college and really the specialty to get to know us better as a board of directors. We are clinicians. We take care of patients, and we also love the boardroom. And so we really do wear several hats. And the main thing I think people need to know is that when we go into that boardroom, when we put on the ACEP hat, when we're representing you as a college, you are the focus, you are the priority. And then, such that any conflicts, if you will, really have to go on the back burner. I can tell you sincerely that we are very, very intentional about disclosing any conflicts that there may be relative to the work that we do, to ensure that we can do this work, which is incredibly important, with integrity.
Well, let me switch gears a little bit. I wanted to talk about ownership in emergency medicine. And I think, you mentioned that when you guys are in that boardroom, you're there to work on behalf of the members. A lot of questions that I'm going to be throwing at you next are actually from emergency physicians. And one of the biggest things I think that is of interest to current practicing docs is, how does ACEP plan to combat the corporate practice of medicine now, especially after ACEP has its own policies and procedures about this?
Absolutely. So the corporate practice of medicine has certainly been on our minds a lot. And we are working to really not just have a statement around the corporate practice of medicine, but also to live it out through our actions. When you talk about the corporate practice of medicine, that's one category, but then in some ways there's overlap with consolidation, right, in terms of talking about consolidation of physician groups and consolidation even of insurers, and then how that folds into potentially the corporate practice of medicine. So there's a lot of nuance to it, first of all. And so I think it's important that we educate each other around the differences between corporate medicine, consolidation, and the like.
Because you were mentioning consolidation. I think that is a very important concept to remember, because we have seen insurance companies consolidating, getting bigger, getting more leverage, as it were. On the flip side, we've seen physician groups consolidating, getting bigger, trying to get more leverage in this interplay as well. Now, you're saying some of this, we need to have a little nuance between sort of consolidation and sort of corporate practice. Can you get into that just a little bit?
Sure. So, corporate practice of medicine really, speaks to more the contractual relationships in terms of how the business is put together and run and the like, whereas consolidation speaks to just that combining or merging of one entity with another. And, at the end of the day, the issue is that corporate practice of medicine should never come at the expense of the patient. It should never result in payment being put over patients, if you will, and their welfare and their outcome. And even with corporatization as well as consolidation, unfortunately, what we see often is that it comes at the expense of the patient in terms of their outcomes, but it also tends to come at the expense of the emergency physician and the clinician in terms of how it impacts the workplace environment. And so ACEP's focus is around making sure that emergency physicians feel safe in their workplace, that they feel supported in their workplace, that they feel that they're having fair, really working conditions, and that in order that they can continue to take care of patients in a way that results in improved outcomes. Unfortunately, when we have some mergers and acquisitions resulting in consolidation and the like. There's a lot of trimming, if you will, in order to create efficiencies. But that trimming, it really just cannot come at the expense of quality care for our patients. It cannot come at the expense for poor working conditions for the emergency physicians. And ACEP is really demanding better for our emergency physicians in that way.
That's a concern that I've heard over and over as well, is that physicians feel that as, you know, efficiencies are created when certain organizations come in and either take over contracts or whatever that situation is, that people feel like staffing is no longer adequate. Perhaps it had been prior. And so, how can ACEP ensure that physician staffing is adequate to the volume that of patients that are showing up in each department across this country?
So, one of the ways that ACEP is looking to improve the workplace environment for the emergency physician is through ensuring that there's adequate staffing, making sure that we tie adequate staffing to patient outcomes and even quality measures. ACEP is launching an accreditation program, actually coming up this year in 24, which will really include several areas of focus. One area is around staffing and ensuring that emergency departments have a standard to follow when it comes to making sure that there are enough people on the ground taking care of patients and linking that to quality outcomes.
And another thing is not only physician staffing, but I think it also goes to say, do we have enough nurses? Where I work, do we have enough psych techs? Do we have enough ER techs? Is there enough ancillary services in the rest of the hospital to help us do our jobs? And how can ACEP play a part in making sure that happens as well?
One of the key pieces is that ACEP cannot function in a bubble. So it's really important that we continue to nurture relationships with other organizations. So, for example, ACEP and the Emergency Nurses Association, as well as the American Nurses Association, intermingle and collaborate all the time. We talk extensively about how we can work together to improve issues such as workforce shortages relative to nursing and techs and the like. And so I think that that's what is going to be the key. The beautiful thing about ACEP is that we do have a pretty large sphere of influence. We have a pretty large sphere, really, of relationships with other influential organizations such as ENA. And together, I think that is how we push the needle. We've had conversations of late with the American Hospital Association as well, Essential Hospitals of America, to also talk about, how we can together ensure that the environment in the emergency department is adequate in terms of providing quality care based on staffing and the like.
All right. Well, let's shift gears again. I want to talk a little bit about the boarding crisis that we've been experiencing for many years now, that seems to have only worsened in recent years. And a specific aspect of that I want to touch on, which is psychiatric boarding in our emergency departments across this country. What's your plan to address this issue?
ACEP will continue to really fight the boarding crisis. We had a summit around boarding a few months ago in Washington, D.C., where ACEP pulled together a large group of stakeholders to the table. We sat down, we spent about 7 hours or so talking about what is going on with boarding, why are we seeing an increase at an exponential rate, what's different today than a decade ago relative to the boarding crisis, and what are the solutions? How can we address this really epidemic that is resulting in literally people dying in waiting rooms across the country, resulting in people staying in the emergency department and really languishing for sometimes months in the emergency department because there's nowhere for them to be admitted to or transferred to. And we know that psychiatric patients are particularly marginalized, unfortunately, when it comes to boarding. We see that those numbers can be increasingly high relative to the time that they spend in the emergency department waiting for placement. And much of the federal legislative efforts in terms of various bills actually focuses on mental health relative to boarding. And I think that that's a really strategic and also obviously ethically appropriate approach to really focus on these marginalized groups that really need us to advocate for them and on their behalf. There are a handful of bills currently right now being discussed, ranging from increasing resources for emergency departments to ensure that there is adequate warm handoffs and community resources and outpatient resources to direct our ED psychiatric patients to. There are grants that are focusing on making sure the infrastructure is strong relative to facilities for mental health and for psychiatric patients to go to from the emergency department and the like. And so ACEP is supporting on the Hill those bills, those efforts legislatively around ending boarding, particularly for patients with psychiatric illness. We will also continue to have discussions with the entities who we invited to the boarding summit a few months ago. It's one thing to talk amongst ourselves as emergency physicians about the boarding crisis. It's another thing to talk to the nurses about it. It's another thing to talk to EMS about it, the hospital administrators about it, the CEOs of hospitals about it, and even patient advocacy groups about it. And all of those individuals were at the table at our boarding summit. We had the hospitals represented, we had the payer represented, we had patient groups represented, EMS, nurses, etc. And until we all have that discussion collaboratively, we won't see the change that our patients deserve. So I'm really excited about that summit, and there's more to come. We've continued those conversations to determine how we can make sure that our incentives are aligned in a way that moves the needle to end boarding.
Well, I'm all for collaboration. However, I feel like when we look at those groups, there's one group that particularly needs to be accountable for this, and this is the hospitals and the executives of those hospitals. Because when we think about it, a lot of times some people will mistakenly call this emergency department boarding. It's not really emergency department boarding. The patients that we discharge are in and out relatively quickly. What this is inpatient boarding and getting patients out of the hospital, either out of the hospital, at least out of the ER, up to the floors. And what is it that we're able to do as a specialty to hold those individuals and those hospitals accountable, not only for things like short staffing, but for staff turnover, but also for boarding itself?
So you're absolutely right. In fact, I actually prefer to refer to boarding as hospital system overload. I mean, that's really what it is. It's really a problem that manifests itself in the emergency department, but no doubt about it, it's a systems problem. And the entire hospital system has to take accountability for it. I think that one way that we hold the hospital accountable is to, again, have discussions with the hospitals, with the CEOs, which, we are having those discussions to really try to understand their angle, and also so that they can understand why we care so much, and then to come together again to figure out how to align our incentives in a way that moves the needle. I also think that we need to really increase the number of emergency physicians who are CEOs of hospitals, right? And so therefore, we would be in the driver's seat. We would know firsthand why it's so critically important to address hospital system overload when we are leading those efforts. And I also think that our accreditation program seeks to address this issue by, again, creating standards to include boarding and wait times that the hospital would need to adhere to in order to meet a certain standard, in order to be accredited, if you will, by the American College of Emergency Physicians relative to their emergency department practice. And so the accreditation program that, again, we're rolling out in 2024 will hopefully create the carrot, will create some standards, if you will, that not only apply certainly to the emergency physician, but to the hospital.
I'm glad to hear that ACEP is pursuing this through its accreditation program. I'm pretty disappointed that CMS got rid of its boarding measure that hospitals had to report on a few years ago, because I think that was one way that, just like all of their other 4 or 5-star programs through Hospital Compare, you could look at one hospital and see who performs better than another. And unfortunately, we can't rely on that as the public anymore because that measure is no longer required to be reported. One thing that I do want to touch on, you said hospital system overload, which is an interesting way to phrase it. I feel like that is loosely related to patient dissatisfaction in the hospital, which I feel like blends over into workplace violence in a way. When patients get frustrated, they get tired of being in the ED, they lash out at nurses and eventually lash out at doctors. And you touched on this a little bit, but if there's anything you wanted to recap about what ACEP's doing in regards to workplace safety, I would like to hear about that.
Sure, absolutely. So workplace safety is also a huge priority for ACEP, and we have participated in multiple efforts over the years to try to improve the workplace environment relative to safety. ACEP did a survey a few years back, which found that there are increasing numbers of instances wherein emergency physicians are being assaulted while in the clinical setting in the emergency department. It is increasing, whether it be verbal assault or physical assault. We definitely know that this is a real problem, and it's not isolated in pockets of the country. It really is, unfortunately, a widespread phenomenon. And so when we got that information and we realized that, we decided that we really need to be proactive about bringing an end to workplace violence, that we need to make sure that our emergency physicians are protected and don't have to go to work feeling fearful in order to be able to do our jobs. So to that end, I personally have actually given a handful of lectures across the country around workplace violence, ensuring that our colleagues and other specialties and other stakeholders are aware of the problem and the degree of workplace violence. I think most people who don't work in the emergency department might be surprised to know how every single day assaults are happening in the emergency department. ACEP has been really championing a couple of key federal pieces of legislation around, one, ensuring that there are channels wherein workplace violence can be reported in a way to ensure consequences to follow. That is a piece of legislation that speaks to OSHA actually implementing these guidelines around reporting workplace violence. There's another piece of legislation called the SAVES Act, which is really about kind of law and order, if you will, in the emergency department. And it speaks to ensuring that people who are, or physicians who are providing emergency care in our emergency departments are protected, that there are consequences to assault against healthcare workers and physicians in the emergency department. And the thing I love about the SAVES Act, first of all, is bipartisan, but it also really has a carve out within it, if you will, to make sure that patients who may not have the capacity to make good decisions are protected, right? And so we know that, the tricky part is that we're taking care of patients who are acutely ill, oftentimes, perhaps under the influence of various substances. And so how do you account for that in a way that is equitable and fair while still protecting the emergency physician and healthcare workers? Well, the SAVES Act takes that into account. And so ACEP has been pushing really now for well over a year to get that SAVES Act put into law, which I think will be really helpful. We also know that a lot of the work around workplace violence takes place at the state level. In fact, there are several states across the country who have had pieces of legislation introduced that increase the consequences of assaulting a healthcare worker from a misdemeanor to a felony, and additionally ensuring that there are pieces in place around reporting and the like. One of the things that I've heard across the country is that there is this hesitation to report the assault because there's the sense that nothing will actually be done about it. And so that's another way that ACEP is really pushing to make sure that emergency physicians know that there's no stigma here. This is really important in terms of reporting it and really making sure that you can be able to safely provide care. Michigan actually just had a huge win legislatively around workplace violence, wherein it increased the penalties associated with assault of a healthcare worker. And so, that and as well as Virginia ACEP recently had a big win around ensuring that there is protection from law enforcement present on site in the emergency department 24/7. And so we are making progress, certainly at the state level. Progress, I think, is also being made at the federal level. And again, once we figure out how to, again, enhance the workplace environment, that is going to really impact everything from workforce to boarding, physician burnout, and to really ensure that we remain strong as a specialty.
Well, I'm glad you mentioned a couple of those states by name because already online you can find our annual ACEPNow chapter roundup out there, and it'll be in your mailboxes pretty soon if it isn't already there in our December issue. We're recording a few days before Christmas, so hopefully an early and or late Christmas gift, depending on how the post office is doing in your neighborhood. So, Dr. Terry, thank you very much for joining us today. I hope your voice sounds a little bit better throughout the week, but taking the time nonetheless to speak to the ACEP members and emergency physicians around the country. Thank you.